Thank you very much indeed. Thanks for coming back on time, and we will start our second session now. And it got quite warm here actually in the first, so if people want to open the doors, that might be more humane. So the second roundtable discussion is about the social determinants for healthy lives. And particularly focusing on homelessness and housing. It seems entirely appropriate in this setting. So without further ado, I'm going to ask our expert witnesses to introduce themselves. So, Penny, thank you.
Hi, I'm Penny Louch. I work at Healthy One, which is the homeless medical centre here in Tower Hamlets. I'm the clinical lead. I'm a nurse practitioner by background, and I work with a brilliant multidisciplinary team of GPs, nurse practitioners and clinical nurse specialists in mental health and substance misuse. And we work hopefully in an integrated way with lots of other services, hostels, bloodborne virus teams, psychiatrists, psychologists, etc., etc.
Are you going around? Yeah. Hi, I'm Maxine Radcliffe. I'm the lead nurse and outreach lead for Great Chapel Street Medical Centre. We're probably the longest running homeless general practice. We're in Westminster, which has the largest number of rough sleepers in Europe. It was very interesting hearing about the integrated care. We work, I think there are about 4 different trusts, that NHS trusts or whatever you call them these days, the bodies that provide services in our building. So we have an HIV consultant that comes in, we have a psychiatrist that comes in, we have a lawyer, so it's very much a one-stop shop approach. And we also do street outreach, so I go and see people that are sleeping rough on the streets as well. So that's and I'm also a nurse practitioner.
Thank you, Maxine. Samantha.
Hi, my name's Sam Donny-Smith. I'm a nurse practitioner by background as well. I'm currently the interim project lead for the King's Health Partners Pathway Homeless Team, which is an inpatient team which attempts to meet the needs of homeless people within hospitals, and that team operates across St Thomas's, Guy's and King's. We are integrated with the homeless health teams within the community, and we are bearing witness to a number of organisational problems, which hopefully we will discuss.
Indeed, Justin, thank you.
Hi, my name's Justin Stevens. I am the clinical team leader for the homeless, refugee and asylum team in St George's NHS Trust. We offer a health visiting service for families in temporary accommodation. We also offer a health assessment service for asylum seekers and refugees in the London Borough of Wandsworth. My background is in community mental health nursing. And I'm also the current chair of the London Network of Nurses and Midwives Homelessness Group.
Thank you. John.
Hiya, I'm John Conmurray. I am health lead for the London HECA Forum, which is the organisation representing local fuel poverty and domestic energy officers across London. There are at least 500,000 homes in London in fuel poverty, and I am also a seasonal health and affordable warmth coordinator at Islington Council, where I look into the various causes of winter pressures on the health service, not just housing.
Thanks, John.
I'm Charles Fraser. I was Chief Executive of St Mungo's, for whom I've worked for about 200 years, and I retired in April. Well, I'm semi-retired because I'm keeping my options open. I think that the thing that we've particularly emphasised in St Mungo's is that although housing is critically important for homeless people, we see homelessness, particularly at the rough sleeper end of the homelessness spectrum, as a health problem.
Thank you.
Hi, I'm Caroline Hattersley. I'm the Deputy Chief Executive here at Providence Row, where you're all very welcome. I hope you're enjoying yourselves and our surroundings. There is still work going on, so it is slightly noisy, but that's kind of how it is for us here. We offer a range of services. I think you talked about what we do. So crisis support, advice, recovery, learning and training opportunities. And more recently, we've started to progress our work with health, in health, working very closely with Penny and others. So hopefully we'll talk about that in a moment.
Thanks, Caroline.
Hi, good morning. I'm Alex Bax. I'm Chief Executive of Pathway. We're a little charity formed to transform health outcomes and health services for homeless people. Came up with a little model of what we've now decided is enhanced care coordination supported by a multi-agency team, which seems to tick many of the boxes from the previous discussion, which is about putting a general physician back into secondary care and putting great nurses and other workers around admitted homeless patients in hospital. Sam's one of our team leaders. Penny's colleague is one of the doctors working to the Royal London. We have a team into UCH. We have also formed a national faculty called the Faculty of Homeless and Exclusion Health to bring together service standards defined by clinicians and service users for these multiple excluded groups.
Thank you, Alex.
Hi, I'm Peter Cox. I'm Director of Health and Recovery for St Mungo's Broadway, which is St Mungo's merged with another homelessness agency called Broadway in April. We provide hostels, outreach, a range of services for homeless people, and a lot of work in health, because health is one of the things that creates and sustains long-term homelessness, or poor health does. And we work with a range of people, offenders, women fleeing domestic abuse, women involved in prostitution, as well as rough sleepers and more traditional homelessness. We work in mental health. We have a large amount of provision in mental health. We provide some specialised services like psychotherapy. We work in substance use, either in partnership or directly, providing things like substitute prescribing and in some areas, whole area drug recovery services. And in physical health, we've just set up the hospital discharge network, which is just about to come into practice, which is a very interesting thing of trying to bring nursing care into hostels and not, as somebody said earlier, replicate hospitals in the community, but create something different in a hostel. And has involved trying to work in partnership with half a dozen hospitals, 5 CCGs and 4 local authorities, and ourselves as hostel providers in different parts of the organisation, and trying to integrate that has been fascinating.
Thank you very much. And I think that's been terrific just to hear the range and scale of the quality of service that is available and its geographical reach. And it's nice also to have a housing perspective from John about what happens inside the homes that people do have. But one of the questions that it raises, and it's one of the questions we would like to prompt, is, so this is very good stuff. What needs to happen next? I mean, how do you go from this to where you feel homeless care should be in London? Yeah, Penny, go for it. I'm sure everyone has a view on this one.
I think it's fair to say there's lots of excellent examples of isolated services providing care for the homeless sector across London, but I think they are isolated. We need to join things up. There needs to be a pan-London approach. Until we can actually join all the dots that make sense for the homeless sector, we're going to all be basically doing the same thing over and over again, and we're not really going to progress and move forward. So I think the key thing is to get us all working together. We've got some excellent around this table, and there's others out there, excellent people doing brilliant work around homelessness. Housing as well has to come with us, but we need to look at a pan-London approach so that we can actually address health and housing needs and actually move people on from where they're at the moment, and use examples of the good practice that we've currently got and take that forward and learn what's new. We haven't got all the answers, we've got some of them. Let's spread the word about what we can do well, learn what we can do better, and let's go out and do it. But we need to do it.
Yeah. Alex, I know you're raring to get in here.
I absolutely agree with that. I mean, we've kind of have talked a lot about this issue. So I think that need for we begin to talk about the need maybe from a professional side for a clinical network for these services, which we see in other cancer or cardiac. These patients are multiply complicated, and there's a lot of professional skill from the clinical front which is needed to be available. The patients, by definition, are homeless, and they cross boundaries and they move across the city because their experience is to be repeatedly denied and excluded from other services and from health services sometimes. So local services, by definition, struggle, and sometimes we are aware of homeless services, for example, which now refuse homeless people because they've chosen to sleep on the wrong side of the street, as it were. So that's why the boundary issue is so important for our patients.
Yeah, thank you. Other perspectives on this? Yes. Yeah.
Absolutely speaks to our experience. So where my clinic is, for about 3 miles in one direction is Westminster, 2 blocks the other way is Camden. And theoretically, I am not supposed to see somebody if they are rough sleeping on the one side of Tottenham Court Road, whereas the other side's acceptable. And we don't have a mapping, you see, so I can look at the health services and I can send that person down a number of different pathways. But in terms of integrating with health and social care, I'm very restricted by borough boundaries. And this is a constant challenge for us. And we actually prepared some case studies of classic patients that we would deal with in our services, which are all quite different, but there's a sort of cohort of patients that we would see that would repeatedly present, and there'd be an issue about, oh, well, they're not a Westminster patient, they're a Lambeth patient, therefore we can't have this team involved with them. And you just end up with a series of different hoops you have to jump through. I mean, I don't know if there's time to discuss these case studies, but they're really striking. This one particular woman, Sam did some sums about her hospital costs, and it's about £300,000 over a sort of 5-year period. And it's just continuous. I'm going to access the service here, and then I'll disappear and I'll go over there. And there's no joined up. So the pan-London approach is absolutely essential and needs to happen yesterday, really.
So how would you argue that to local government? Because you know the feeling when you mention pan-London anything.
Yeah.
So I mean, we do, and we do this all the time, but not just about cost. It's also about governance and who's in charge. Who's in charge, who's accountable for pan-London stuff. I mean, how would this work? Talk me through a model, because you must have.
It's complicated. So we're supporting some services in Bradford, in Brighton, and in Birmingham and in Manchester. And I have to say, it's a dream in those places because of the boundary issues being so much simpler. So housing, so most of our teams in London spend most of their time battling other bits of the bureaucracy, not doing healthcare, but fighting multiple bits of other people's bureaucracy to try and get something for a patient. When you go to Bradford, they just don't have to do that because Bradford City accepts some duty to house everybody who's in Bradford or something. And in London, any local boundary, always in the end, a local authority doesn't need another expensive, complex, high-needs alcoholic man to look after. So you can see why they don't need to accept the patient. So it is a political question. I think the services view is it just needs to be taken above that level. Housing is crucial, but at the moment it's incredibly hard and getting harder.
Charles.
Local connection is a mechanism for incentivising disregarding certain groups of people. And there's been a huge amount of investment in homelessness services over the last 20 years, and the quality of those services has increased beyond recognition. And yet, funnily enough, the people at the bottom of the pile are the same people who were at the bottom of the pile 30 years ago. And so local solutions are not the solution for this client group. There needs to be a regional approach. And I think that it takes two forms. It's partly for, as Penny said, there are some excellent one-off services and there are some gaps. It's how do you deal with the gaps in service provision across London? We cannot wait for local councils to try and do that through health and wellbeing boards because they all have different priorities. So I think we need some regional London-wide approaches. Where's that coming from? It's got to be the mayor. Is there any money? I don't know. But I think that's really where the safety net, if you like, for this population has to come from. Can I make one other point? Because you asked at the introduction stage about how you see things, what needs to happen in the future. And I think that the group of people we deal with are characterised by multiple exclusion. And this is not a sort of impersonal, objective description. This is a group of people who are actively excluded by services which are set up and should be helping them. And I think a fundamental issue is poverty. There's an extraordinarily high rate of unemployment. At St Mungo's, and some of you will have heard me say this and be bored by it, but in 1983 we conducted a survey of our hostel residents. 86% were in paid employment. Today it's 4%. The labour market has changed, but the programmes designed to help unemployed people get back into work do not work, particularly not for the long-term unemployed. So when you've got 2/3 of people who've been out of work for 5 years, they're on the scrap heap. And when 40% of them can't read a form, their prospects are bleak. So I think that tackling poverty is one of the best ways of getting people, of improving their health. And that means for us in St Mungo's, them in St Mungo's, I should say now, shouldn't I? It means not just income through things like the living wage, but I think you've got to look at expenditure. And I thought the idea of the living rent was a really, really good idea. So I hope that is an issue that public health can actually take up at the London level.
So can I just ask Sam, because I wanted to reflect on some of that and then we'll come back to this, Sam.
Just a quick point. I mean, I'm intensely proud of what Tower Hamlets does and what projects like Maxine does, but I'm also aware that it illustrates extreme postcode lottery, which is what you define. You know, where you actually happen to be or where you're homeless actually will define what you get. And it's absolutely extreme compared almost to any other service that you provide. I'm also aware that in Tower Hamlets that we've created dashboards for everything. League tables, if you want to call them that, in primary care. So you can see how a practice is performing. Any practice can see by name how any other practice is performing. My question is, have we got a dashboard for London? Surely that should be a key place to start. Actually, what is each CCG doing? What is each local authority doing? And where are the services? Because I suspect we would create a league table that would start driving political change. So is anyone doing that? And is that something we should ask Boris to do? And if we could get 5 minutes with Boris, what else would you be asking him to do?
Well, I would love to get the perspective if there are local government folks sitting in the audience, what they thought about that. But let's keep going, and John, of course, as well. Sam and then John.
I don't know, I suppose I feel that there might be some simple solutions. In terms of the local connection thing, I do gather that in Scotland they've done away with local connection for people who have no clear connection. Yeah. And one of the case studies I've got here is somebody who whose family was in Lambeth but who was actually living at work. He split up from his partner and he was living at work for a long time. His health deteriorated and the two boroughs were constantly arguing about whose responsibility he was. Yeah. In the meantime, he was repeatedly attending in A&E and repeatedly attending for social reasons. I mean, you know, this isn't a huge cohort of people. If you did away with the local connection with those small cohort of people, you'd get them housed very quickly. And the longer they stay homeless, the more likely they are to stay, you know, out non-economically viable long term, because, you know, they're being inducted into a life which is not helping them or empowering them to get back to work. So why not just do it? I mean, who's the boss?
Who's paying for it is the question.
But it isn't.
Yeah.
Over Pan London, it's not going to cost any more, is it?
Yeah.
It's just about the allocation of the resources.
We had John on the, and then.
I suppose representing 33 local authorities, I have to speak up for them. I hear in my area, fuel poverty and energy, my experience is that regional schemes don't work. Most of you probably won't be familiar with Renew, but it was set up as a regional programme to tackle supposedly energy efficiency and fuel poverty. They brought in people from Capita, despite the fact there's a huge level of resource in local government itself to deliver these sorts of programmes. It's failing. National programmes are also failing. I had a client come to my team who, a 74-year-old gentleman with serious mobility problems and respiratory disease, who'd called the National Energy Efficiency Helpline 6 months ago. Didn't hear anything for ages. Someone came round, told him there's nothing he could do. He eventually got onto our local disability action in Islington, who then got onto our lead member for health, who spoke to me, and I got him a new boiler in 2.5 weeks. Now, he'd been waiting for 6 months because of failure of a national programme that's clearly not working. And in Islington, we have a seasonal health interventions network that last year had 2,800 referrals, increased quite significantly in the last 3 years. Only about 4 or 5% of those came from the health service. Now, my concern is that people in the health service aren't taking housing conditions seriously enough. If there was someone in Islington who needed a new boiler or insulation or anything like that, then I would hear about it because they'd come to us. And I can count on one hand the number of referrals that come from GPs, for instance. And that picture seems to be very consistent right across London. There are some areas that have tried to copy the Islington model, like Wandsworth, Hackney and Lewisham, but the picture I get is that both CCGs and public health are not engaging in housing quality. And when you consider there are at least 500,000 homes in London in fuel poverty, there are 2,500 to 3,000 excess winter deaths in London every year. For each of those deaths, there are approximately 8 emergency hospital admissions and 100 additional GP consultations. The NHS has a lot to worry about, and it's not taking it seriously. But there's some very excellent work taking place on the ground. I think the argument shouldn't be not for regional programmes, but for effective local schemes to be rolled out across London.
So here we have a sort of a balance of views, really. Peter, I know you wanted to come in.
Yes, I mean, very much think that in London you have to have the pan. We very much in favour of a pan-London thing, and I don't think it's that difficult actually. You've got NHS England has got a London Forum, Public Health has got a London Forum, and the health commissioning side of it shouldn't be difficult. Housing, actually, we're talking about health-related housing here. And the integration, we talk a lot about integrated care. It's usually integration between primary and secondary, between mental health and physical health, between physical health and social services. For us, integrated care is between housing support and housing and health. But that's just about a smallish number of people, and there could be a waiver in local connections for people with a health-related need. Before we get to the Scottish principle of abolishing it altogether. What Scotland did as well was give people responsibility, and I think the Director of Social Services earlier hit it exactly. If you ring up the Director of Social Services, send them a letter so they've got something in writing, contact your counsellors, you will get a service. And most rough sleepers and homeless people and people involved in prostitution and illegal immigrants and people refused asylum can't do that, and so they're excluded because nobody's responsible for them. But actually, all these people have got duties to tackle health inequalities, which are meaningless, completely meaningless. And the Health and Wellbeing Board's duty is meaningless. And if people can be excluded, and they set up criteria. So a mental health service, if somebody turns up and they've been drinking or they take drugs, mental health services say we won't treat you. And that includes the rapid access ones in A&E. So they don't work with our clients. So most of our clients have mental health problems, they can't get any treatment. They're deliberately excluded. People with no recourse to public funds are deliberately excluded from housing. We're not allowed to house them. We can't get any rent for them. And so on. So there's these deliberate exclusions. And they turn up at all these services, and all these services think of a good reason for excluding them. And nobody has to take responsibility. But if every service had a legal responsibility to do something about that person, we would do something. So if we all behaved like adult directors of adult social services, if we had the money, because that's the other thing is, although institutions, things are directed around the institutions, as you said, the problem is the institutions have got the money. And they won't let us have the money if we don't do things their way and support their power structures. So there is a problem in that. So I think there's a thing about responsibility and then distribution of that.
Which is, of course, what Marmot would say all the time. Caroline, I'm aware you haven't spoken.
It's really,
Justin.
I think the multiple exclusions thing is really key here. A lot of the clients who come through our centre are really chronically disengaged from services because they've experienced those multiple exclusions, and they get to a point where they think, what's the point? What's the point of trying? I'm really interested that you've got those case studies, because I actually think, as we were saying, the resources are probably, however you structure it, the resources needed are the same. And actually, there are savings to be made by structuring things slightly differently. I mean, I'll leave that to the policymakers. That's kind of their expertise. But I think if communicating the experiences of individual clients, actually there is a job of education there in terms of educating policymakers, decision makers, to understand what their structures mean for, Joe, for Peter, for Mary, for whoever it might be. And I think if we bring it, certainly for me, if we bring it back to the individual client and share those experiences, then maybe we can start to make some of those changes and make the case through those case studies. And we've all got stories. But so that we don't end up with clients getting to a point where they are so disengaged that it takes so much energy and effort to try and help them to see that there is a future and there is a possibility here. And I think, just picking up on what John was talking about, one of the other things we haven't talked about here is actually, and I think you're touching on it, is actually the prevention side of things. So individuals who are in housing, who are having difficulties and challenges, who are actually at increased risk of potentially losing that and becoming homeless and then experiencing more of those priorities, those sort of crises. So I think there is a prevention agenda as well to be looked at a policy level.
Yeah.
Really.
Justin, I just want to make sure everyone has a voice. So Justin, please. Yeah.
I just wanted to make a reference to some of the existing pan-London networks that are actually out there and that do serve as, I suppose, potential solutions to some of the problems that we're talking about. One of which is the Wanderers meeting, which has been hosted by St Mungo's. And this is a pan-London meeting where the outreach teams will swap information. Now, I know that information sharing from the first session was identified as an issue, and it's a massive issue with certainly in homeless services. And the Wanderers meeting is a good example where you will get professionals from all the London services swapping information about people who move from borough to borough. That's one example. The other example is the London Network of Nurses and Midwives Homelessness Group. It's a pan-London organisation of predominantly nurses that will meet and swap, I suppose, discuss best practice. We also recently had our own conference that we completed last month. And indeed, two of the main points that came out of that was around pan-London commissioning and also pan-London information sharing, which is seen as a major problem. But there are still organisations out there that can work with this, and I think it's really important that we are aware of those.
Thank you. It was one of my questions is how do things get shared? Sorry, Sandra.
We'd love some more resource to build on the pan-London networking. I mean, if we can do that, that would be brilliant. I just wanted to say something quickly about the no recourse. One of the case studies is about a 73-year-old undocumented migrant who's an insulin-dependent diabetic who's had 3 admissions, including one for ketoacidosis, who has been refused registration in 5 GP practices, including 2 homeless practices.
So
that's a real example of what's happening. And for the homeless practices, in all fairness to them, in both cases, it's because they are being told, you can't encourage people into the area. This person is homeless on the buses. He's staying around people that he knows, and is not in Westminster. And because of the different services and whatever, obviously he's migrating to where he thinks he's going to get seen. He's not being turned down because of his illegal migrant status. He's being turned down because of his homelessness and because he hasn't got an address. And we know that's illegal, and yet it's still happening.
So Sam, just to pursue the one, because one thing we didn't cover is the quality of primary care in the last session. I mean, our Sam here has suggested a dashboard of showing and telling, really. What solutions do you see in primary care that would work from your perspective? I mean, taking it on from the dashboard, and I think Penny might want to comment on that too.
I just think, actually, at a very simple level, I think GP receptionists need education. I mean, I think that's a real priority now about who they can register. And to make them think twice about the challenges that people have as well when they register, particularly in our client group around language, around embarrassment, around conflict. There's some real issues around GP registration which are impacting on secondary care usage, and they are also impacting on long-term health outcomes, i.e. this person's going back into hospital in ketoacidosis. Yeah.
Just to pick up on that point from Sam about registration with GP practice, I think it's to reiterate that there is a pan-London registration policy that all GP practices should be abiding by, which means that people shouldn't have to provide War and Peace to register with a practice. They haven't got to provide a passport and addresses and all the rest of it. It is at the discretion of practices, but practices can use the rules that they've always existed under to prevent registration. So I think there is a policy out there. It's been out there for a number of years. It needs to be applied and it needs to be used, which would resolve some of those situations. The point I was going to make is I'm a provider, I'm not a commissioner, so excuse me if it's a very simplistic solution, but why can't all CCGs in London have their budgets top sliced by, I don't know, 1%? I don't know the figures, we need an economist to work that out. That money goes to NHS England, it sits in NHS England, who can then run a directorate that actually looks at a pan-London service and do the same for housing. That they can top slice, I don't know how it all works, I don't know the detail, but it seems very simple. Top slice those budgets, the money's there. The money's being spent in this disparate sort of way at the moment. Take the money away from all the CCGs, and then there will be some CCGs that complain who say they haven't got any homeless people in their boroughs. I can assure you they do. They either don't count them, or they've been kicked out to touch, and they've gone into another borough. I mean, there's examples that I know of locally in the city where they hose the streets down at night at 3 o'clock in the morning. So you're not going to sleep on the streets of the city at night, are you? You're going to come to Tower Hamlets or go somewhere else. You know, it's simple to clean your borough up, but actually you've still got homeless people. You top slice the budgets, you use that money, housing as well, it sits with NHS England, we can look at a pan-London approach and just get on with it.
Penny, thank you. And Peter?
Yeah, I agree. A lot of sympathy for that, because it can be done. And the housing one was done actually in the Rough Sleepers Initiative. All the housing associations contributed a certain amount of stock which was set aside for rough sleepings, and of course that was a centrally imposed solution on rough sleeping which worked. The rough sleepers unit was run by central government and there was a reduction. But in terms of primary care, not all areas have the same degree of problem. Not all areas need to have the same degree of provision, and we don't need to have commissioned in every CCG a full set of services. We need something which distributes that expertise, and there's probably economies in distributing expertise and enhancing the service that some GPs can offer, and having perhaps a more mobile workforce that will go around places and deliver the health service not just in GP surgeries but in primary care where people are. So I think there's different models for doing it. And the other thing is we need more mental health treatment, accessible mental health treatment, and we need it in primary care, not in hospitals, not in clinics, not in secondary care. Accessible psychotherapy is really important. That we've got people with very high levels of mental health problems and they're getting turned away because of drug and alcohol problems, and we don't have systems that work with them. Our psychotherapy services in the NHS are almost inaccessible, and we provide some, kids company provide some, Place to Be provide some, lots of voluntary agencies provide accessible psychotherapy. The NHS doesn't.
Thank you. So I'm going to take Charles and Sam, and then I'd very much like, because we're sort of over time a bit again, I'd like very much to get the perspective of people sitting in the audience. So Charles.
It's a small point, but I think that the complexity of the problems often makes one think the solution is impossible to find. There is an example from the GLA of housing rough sleepers, where the mayor persuaded local authorities defined a cohort of very long-term entrenched rough sleepers and persuaded local authorities to suspend the local connection rule. Hey presto, over 100 came off the street. So relaxing the local authority policies helped house people. It's not fanciful to deduce that applying them keeps people on the streets.
Yes. Thank you, Charles. It's very interesting. I mean, we need to remember what we learned from these things. Sam?
I want to take up Peter's point, because while I agree you need to focus the services where they're needed, often where they're needed is where they are. In other words, services like Penny's act as a magnet, and actually certain areas are quite good, like you describe in general practice about pushing homeless away. So my question is, around Jenny's question, by all means provide difference and inequity of services actually based on need, but my question is around the cost. I would argue probably the cost should be shared equally across London. At the moment it's not. It's disproportionately held actually by certain areas who go way beyond what they need to in terms of providing for this group. And that's a massive inequality and inequity.
I'm not sure you can do that actually. I think that the rules against it, the Bexley problem with when there was Fares Fair, if you're old enough to remember Fares Fair, the mayor at the time introduced a single fare across the whole of London, and Bexley said there are no tube stations in Bexley, therefore we won't pay it, and it was a top slice across all the local authorities, and they took it to court and it went up to Supreme Court, and you're not allowed to apply something completely across the board without taking into account individual circumstances in most situations. I think that wouldn't work. I think you should take into account as well. I think you should take into account local need, and I don't think it's true that services of excellence are a magnet in a negative sense. if anything, that's a good thing. And it's always struck me as strange that if lots of people want to use an NHS facility, they try and close it down. I think that's bad. So A&Es are bad because people want to use them. If you're Tesco's, you say, that's fantastic, let's make it bigger. It's very weird. If we have good services and people go there, let's go. We can't reproduce all these services in every place. I think it's not real.
I know Alex wants to make a quick comment, and then I'm going to ask for comments from the floor.
It's that point about the resources. I think we would argue that for this population, there's something called the inverse care law, people may be very well aware of, which shows that in health particularly, resources tend to be dragged to the wellest and the healthiest and the most affluent populations and tend to be pulled away from the neediest, even though we're supposed to have a needs-based service. And this population illustrate that many times over. So if you look at the way primary care for this population is funded, the specialist services, they sometimes get a bit more than mainstream primary care. The needs of the patients on their lists are every patient on their list has multiple comorbidities. And that's not what a standard practice has, and yet they get an analogous amount of money to a mainstream GP who's got a list with 90% of the population very healthy. So there is an issue there about both across the city, but then within the health service, how you actually, I believe, we're supposed to drive resources towards health need, and this population, in my view, need more resources.
Thank you. So I really do want to give people a chance to say something. Now, if they've nothing to say, we'll come back. But I gather we could talk all day because there are brilliant advocates around this table. So while the homeless folk may not have a voice themselves, they have your voices and that's brilliant. We want to hear more of it. But I'm sure there are people who want to perhaps reflect or respond or add to that. So do we have anybody who wants to actually reflect or question or comment or challenge what they've heard? And please do say who you are. Nobody at all. Oh, we'll simply go back to our wonderful panel if that's the case. But, does everyone agree with everything they've heard here? I mean, do you want to top-slice boroughs?
I think the idea of pooling more resources is very sensible. And a lot of you, as you said, around the table working in similar areas, and I've visited many other very good facilities, and the idea of more cross-working and ignoring borough boundaries and the connection, I think is a really interesting idea, and I hope that's something that you can explore with your submission so we really take that forward.
Brilliant. Okay, well, while you're all thinking, let's go over to Penny now, so if we wanted to.
Right, I think just picking up the point that Alex was making about the inverse care law and how resources tend to, the wellest get the most, and the less well and the less now homeless population can perhaps get the least. Yeah, I think an example, obviously, at Healthy One, we employ a clinical nurse specialist for mental health. It's an unusual thing to do in general practice. You don't normally employ a mental health clinician. Clearly that adds to our costs, it adds to our cost per patient. That's something we constantly have to argue against, both at CCG level and also at NHS England level. Why are you so expensive? Because we're providing lots of services. We're also involved in a number of initiatives, which again are costly, but it serves the needs of our patients. We're involved in a mental health project trying to keep our patients who haven't got a defined mental health diagnosis but have got mental health issues, so anxiety, depression, stress, from out of A&Es and occupying mental health beds because they go into crisis. It was a pilot, it's about to come to an end. There doesn't appear to be any more money, that's going to stop. Those patients will go back to A&E, their lives will go back to where they were. There isn't a cure. The other big initiative we've been involved in is the Pathway Project. One of our GPs has been working very closely with Pathway, was part of the trial. Again, we're battling now. Where's the money going to come from? At the end of June, that project will end as far as I'm aware. Barts Health have got no money. CCG, it's down to you, but it's been a piece of work that's been going on for 3 years. It keeps homeless people going into hospitals, working with generalist GP going into hospital, working with clinicians there, making sure our patients hopefully stay in hospital for the required amount of time, and then planning their discharge to a safe place with all the agencies. That is about to end unless somebody gives us some money for that to happen. So we do lots of work, but it is always about the money and the resources to make it carry on. So, we can't do anything more, I'm begging.
Can I bring this back? So I think the session was about health inequalities, and we would suggest that this population represent an extreme of a social gradient. So they're at the bottom of every gradient, and they're a comment on our total societal attitude to how we respond to inequality in our society. And the fact that we're failing these patients would suggest that we're not collectively meeting our statutory health inequalities duties, and nor are any of the individual services with those duties on them. So I'm attracted by the idea of a dashboard, because we'd love to hold people to account for the fact that these patients are dying 20, 30, 40 years younger than they should do. The life course is interesting also because these patients represent a systematic failure of systems previously in their lives. So 60% of the population have lived in care and will have been in prison and have had catastrophic early childhood experiences, high degree of personality disorder and other complex mental health problems from early childhood trauma. So these people are casualties from going back 10, 20, 30 years. One of our clinicians talks about them. The current 40-year-old homeless man is a casualty of the recession before last, when things were tough and they couldn't access the bottom of the labour market. So for the London Health Commission, I think if London can't fix, and as Charles said, this is a relatively small population, it always has been. If we can't fix it for this population, we're not, what kind of a city are we, would be my question.
I think that depends on what the fix is, isn't there? And I think there's some issues here about when we deal with this issue, and predominantly what we were talking about is dealing with the here and now problem, but we need the preventative agenda as well. And it was quite interesting that the definition of, you weren't just dealing with people sleeping on streets, but the sofa surfers, some of the other issues that are presenting themselves that are going to cause problems longer term. And I think that's a problem. I think that's a problem with this debate. And I think what we could probably do as a commission is shine a light on that you've been working in many years about some of those issues, of how they present and how they're only going to get worse because the nature of, I think, the housing crisis in London and how it affects individuals at different levels. So I think there are those issues. What I thought was very interesting about this issue is the relationship between the third sector and the NHS. And I think that's quite interesting about how they feed predominantly some of your clients, do you know what I mean? Predominantly, even though word of mouth is very powerful. And I just, like to hear a bit more about that relationship and what, I think we heard already that, one of the issues on the preventive side that they thought the NHS could do more around some referrals about fuel poverty and some of those issues. But on terms of that relationship, it's a two-way relationship. How does that develop? What is that vision that we have in terms of this specialised sector? I think where we need to go, we need to have a complete review of what we're doing, not just in terms of the here and now, but how do we get into the preventative issues, because that's it. Well, that's got to be key for us, to be honest. But what does that relationship look like in the future? Can it be improved upon? Where is it going? Do you know what I mean?
Yeah. And Sam, I know you wanted to get in. Sorry, just it may be related. Yeah.
Kind of a quick point. In Tower Hamlets now, we've got a special contract with GPs which gives 3 times the amount of capitation amount to somebody with complex care needs who's usually elderly. I suppose my question is, there's no financial incentives around the housebound. Could you mirror that, either in the way we've done it, or alternatively personalised budgets? With all the difficulties and complexities around that, but at the moment, what you define in general practice is fundamentally a complete perverse incentive, actually, not to take on these patients. Now, put a pot of some money behind them, crudely, actually, and then... So what's your views on personalised budgets, these sorts of different contracts?
Now, I'm just very aware that we're now at the end of this session, and in order to be fair to the next group who are just as passionate about you as wanting to get their voice heard, I'm just going to take one final comment from Peter. I know you'll understand this, but what we've had here is a very early airing of a voice that we don't normally hear, and one of the reasons this commission is here today is that we don't want to just talk about closing hospitals or opening hospitals or any hospitals. We want to talk about people in London. So I do hope, although it hasn't been adequate for all the issues, that we can take some of the case studies and continue this, because we've a lot of issues here. We need solutions, though, that are workable and legal, as you've said, Peter. So we'd love to do loads of things, but it's what we can do in reality is where we need to go forward. So Peter, and then Caroline, and then I'm going to close. Okay, thank you.
Sort of quick things on all of those. We'd love to see personalised budgets. We would love to pilot in partnership with our NHS colleagues personalised budgets for people with complex needs, rough sleepers. I think it would be fascinating and easy to do with 100, 200 people, something like that. That would be great. There are other ways of doing it. I did some work in Italy, and the Department of Health there, the government, holds a central fund for migrant populations, which includes me. So if I, as a tourist, I get injured and go to a hospital, they categorise me as migrant, and it's paid for, and it doesn't come out the local budget. So a local hospital where they get a lot of homeless people can treat them and charge to the central budget. That's a good system, I think. So those are the things on those. In terms of working together, we're setting up this hospital discharge network with these multiple partnerships with CCGs, local authorities, and primary care and secondary care. We found that lots of these people weren't having conversations with each other. The director of housing, or lead in housing in one local authority, went into the building of the CCG, which was the same building the PCT had been in. He'd never been in there before. He said, I'd always wanted to come in here. Very strange. Primary care and secondary care didn't talk to each other. We didn't talk enough to health service, and they all talk different languages, different priorities, different budgets, and different rules for exclusion. That's the other thing. Prevention, yeah, but it's 20 or 30 years in advance, so it's really easy to recognise the people who will become socially excluded. I can go to a nursery down the road and I will tell you who's going to be in Providence Row in 30 years' time. It's very easy. You can see what's there, and there are plenty of things to do about it. Social exclusion is a process. The reversing of it is a process. It falls, I think, in public health, but it also involves mental health. And we don't do things. Poverty is part of it, but it's about parenting, particularly parenting and education, and a bit of resource put into that. But I think at the moment they're closing down connections and everything else.
So Peter, these things, as somebody said, everything is connected to everything.
Yeah, but
famous person.
There are solutions. They're all there.
Yeah.
Yeah,
and finally, Caroline.
Very quickly, and I won't go into it too much, I wanted to respond to Len's point about building connections between the voluntary sector, third sector and health. And there is a real will to work together, a real passion for that, and Penny's alluded to a couple of projects and programmes, some of which are involving the third sector, like the hospital. We're involved in the Hospital Pathways project. The biggest challenge, and actually the easiest solution, is actually to look at perhaps how those programmes are funded and supported, because it tends to be that things are funded as innovative new programmes. We then discover they work, but then we have to create something else innovative and new to fund it. So that, you know, and there is something about taking the results of those programmes, investing in things that the Hospital Pathways, your mental health project, I know that's not necessarily involving the third sector, but those kind of projects, seeing that they work, seeing that they make a difference, and then committing to fund over the long term. And that way those relationships can be built, can be sustained and developed for the benefits of the people we support.
Thank you very much. I think we've had some brilliant advocacy here and lots to think about, and I do commit to you that we'll take this forward and consider this further. But for this morning, thank you very much for joining us.